It's my pleasure to welcome you here this morning for the second Heart Expo. Last year we celebrated the 30th anniversary of interventional cardiology, and this year we're celebrating the 30th anniversary of heart surgery. In the time that has transpired over those 31 years, there has been continuous progress made in cardiovascular care, and this morning we have an opportunity to give you several examples of that. There are a variety of demonstrations in the lobby outside and in the main lobby of the Broadway building, and we'd invite you to go out and look at those. We'd also invite you to participate in the health screening, and the lines for the health screening are starting in the Health Fitness Center right outside the main doors to the Broadway building presentation area. One of the things that I'm particularly proud of in terms of being associated with the International Heart Institute is the broad number of people who participate in providing cardiac care. And this morning you can identify many of those people quite easily because they're wearing red shirts. This is really a team effort, and we're very proud to have the team assembled here to provide patient care that we do have. And I hope that as you have a chance to walk around and look at the demonstrations, you'll also have a chance to get to meet these people. We have a series of presentations that will occur here in this room this morning. And the first speaker is somebody who is really a very central figure to cardiology here at St. Patrick Hospital. It's Dr. Stan Wilson. Stan was one of the first cardiologists involved with the interventional lab program here, and he continues to be an innovator. Stan has recently developed a new coronary stent, which is in clinical trial in Europe, and we hope will come into the United States in the near future. It's my real pleasure to introduce to you Dr. Stan Wilson.
Well, I'm welcome, and I'm proud to have been a participant in 30 years of cardiac surgery at St. Pat's. I have more mixed feelings about being an elder who can speak from the perspective of having been here before and at the beginning. I want to thank, I'm going to do several things. I want to first thank the people who have, the companies who have sponsored this event, and we need to recognize them. Abbott Vascular Devices that we use every day, Allegiance Insurance people, Aventis, Blue Cross Blue Shield, Boston Scientific, GE, Guidant, Medtronic, NMT. Without these sponsors, we couldn't do this. I'm going to provide you the wise elder's perspective of the history of what's happened here at St. Pat's. But before I do that, I'm going to reintroduce you to the star of the show, which is your heart. And I'm going to put up some things that we'll let Beth point out while I'm showing you here. This sits in your chest. It's about 1/3 this size. The most important part of it is this big, thick muscle, which is a pump. Its job is to pump the blood to all the organs of the body, and it does that a little over once a second for all the time that you're living. It is assisted in that job by 4 valves, the most important of which from the surgeon and the cardiologist standpoint are 2. This valve, called the mitral valve, that allows blood to go forward but does not permit blood to go backwards and flood the lungs when this muscle contracts. And if you look up in this model up into here, and it's right in the center of this model, which makes it more challenging to get to for a surgeon, I'm quite sure. The valve that leads out of the pumping chamber and to this big hose, this big trunk of the tree of all the arteries of the body. That's called the aortic valve, and it allows the blood to get out and doesn't allow the blood to fall back in. The other components of, and I should say that later on today, you're going to go inside the OR and see a replacement of this valve, this aortic valve. The other components that occupy most of the energies of cardiologists and cardiac surgeons are the fuel lines, the coronary arteries. Coronary artery disease is the #1 killer, most likely thing for you to die of. The coronaries lie on the surface of the pumping chamber and send feeders down into the pumping chamber muscle. When blockages develop in these arteries, and that's what we call coronary artery disease, then one of several things happens. A narrowing in these arteries will not permit all of the fuel to get to the heart muscle that the heart muscle asks for in times of high need. The patient finds that he gets discomfort when he tries to walk up a hill. When he stops and rests, the fuel supply gets adequate again and his symptom goes away. That's a symptom we call angina. That's something that cardiologists and heart surgeons deal with every day. If an artery blocks off, usually as a sudden event in an active plaque, a portion of the heart muscle dependent on that fuel line begins the process of dying. It takes a few hours. That process is called a heart attack. The surgeons were the first to provide a solution for blocked arteries. And all of the solutions for dealing with heart artery blockage have happened in my professional lifetime. The first bypass operation was performed a year after I graduated from medical school. But the surgeons create bypasses that go from this big hose, the aorta, down to the coronaries, detouring around the blockages. The process called intervention, which is a word that didn't exist when I came into practice in Missoula. Intervention refers to fixing coronaries with catheters and balloons and stents. And the interventionalists, in a less invasive way, through a poke in the groin and a catheter, introduces the catheter into a coronary artery, comes down the coronary with a wire, a balloon, a stent, which is a metal cylinder with holes in it, mounted, compressed over a balloon, into a blockage. The balloon is inflated, the stent is pushed into the wall of the artery, and the blockage is repaired. All of this has evolved in my lifetime, which is pretty remarkable. It's magic stuff. I'm going to walk you through 30 years of history, and I think of this as a tradition of excellence, and St. Patrick's Hospital has quite a remarkable story. It begins in the late 1960s when Jerry Dietert and Hal Brown. Jerry's here today. Stand up, Jerry. Jerry Dietert and Hal Brown began establishing a coronary care unit at St. Pat's and a program of teaching doctors and nurses and technicians recognition and treatment of heart rhythms that have to do with heart attacks and heart disease. And it is worth knowing that when I finished my training at Johns Hopkins, there was no coronary care unit at Johns Hopkins. They hadn't figured that out yet. There was a coronary care unit at St. Pat's Hospital. In fact, they were sprouting up all over western Montana with the leadership of Drs. Dietert and Brown. And so this tradition of excellence and leadership begins before I arrive, certainly, and Jerry has a right to be proud of that. I arrived in 1973. In 1974, the heart catheterization lab opened. We celebrated the 30th anniversary of that event last year at this expo. There's a long tradition of excellence and leadership in heart catheterization since. 1 year later, in 1975, Dan Adams performed the first bypass operation and first open heart operation here at St. Pat's. And a little later this morning, we'll introduce one of the first patients who was a patient in that program. The long tradition of excellence in surgery is followed with evolution of lots of new techniques, and many of them promoted and developed here. In 1981, Life Flight began. Some of you will remember in the very first days when the police used to block off Broadway so that the helicopter could land in front of the old hospital. Now we have a highly efficient team saving lives every day. In 1982, we began to do what we call coronary intervention, which is fixing arteries with catheters. Well, there's a long tradition of leadership in that has followed. By about 1984, the physicians here at St. Pat's were taking a leadership role in expanding the use of intervention and fixing more and more patients who had coronary disease, allowing them to have fixes short of having surgery. That tradition has continued. In 1989, the first Rocky Mountain Valve Symposia took place in Missoula. Dr. Duran was a part of that symposia from the beginning. This is quite a remarkable thing for Missoula, Montana, with the masters of new revolutionary techniques in valve surgery coming to Missoula, operating at St. Pat's Hospital with a live audience of over 100 cardiac surgeons from all over the world. Happens once a year. If you look around the world for the most comprehensive, definitive program to go to learn valve surgery, and particularly tissue valve surgery, you find that happens in Missoula, Montana. In 1995, the International Heart Institute was founded. Dr. Duran came to Missoula. It's approaching 10 years. This is quite a remarkable thing with a really world leadership position in research and teaching and evolving technologies that will shape the face of cardiac future in the future, the cardiac surgery in the future. In 2003, we put in the first drug-eluting stent to be placed in this part of the world was placed at St. Pat's, and this is another major step in providing lasting care or lasting results for patients with heart disease. I'm going to just give you two perspectives on looking at 30 years of cardiac surgery at St. Pat's. And the first of those perspectives is what 30 years of cardiac surgery has done to this hospital, not just in the care of cardiac patients, but in the care of all seriously ill patients, in fact, all patients. And it's very clear to me, watching this happen, that this has created what I could term a hospital-wide culture of excellence and competence and confidence. This isn't just a few highly trained surgeons. This is nurses in the OR, this is nurses in the cath lab, nurses in the ICU, nurses on the floor. It's technicians in the OR, technicians in the cath lab, telemetry techs on the floor, respiratory techs, blood bank techs, physical therapists, every aspect you can think of taking care of sick patients. And all of that is just head and shoulders above a hospital that doesn't have that 30 years of cardiac surgery. And the reasons are, first, they're quality people, and we have lots of those. You're going to meet some in a few minutes that have been here through the whole process. There's a repetitive exposure to challenging critical care patients. Everyday cardiac surgical patients, challenging problems, highly efficient critical care, and the cumulative impact of decades of doing this. It just makes the place different. This isn't just a good hospital, this is a great hospital. And finally, there is a team pride and excellence. Everybody who is a part of this program knows they're doing something extraordinary. They're proud of it. They rise to be the very best they can be and to contribute to that program. And then the other thing that will make Carlos smile is I would point out that this is that the other perspective I would give you is that this is an environment of team cooperation between cardiologists and cardiac surgeons. It's a long-term dialogue. Evolving surgical techniques, new techniques, intervention, evolving role of intervention, always trying to find the best solutions for the patients, lots of interaction and communication. And I would point out two things that I think are really crucial. For 32 years, every Wednesday morning, there's been a conference about cardiology issues, cases, interaction between cardiologists and surgeons. And since Carlos arrived 10 years ago, there is a meeting every Monday morning in which the cardiac surgical cases of the week are reviewed, cardiologists contribute. We all try to decide how to do the best thing. That's an important part of that tradition of excellence. But Carlos is just an incredible man. He is the director of the International Heart Institute. He has a chair at the university. He is known throughout the world to any cardiac surgeon that you wanted to mention as a cardiac surgeon, as a scientist, as an innovator. His research has been fundamental in human and animal valve transplantation, and his device that aids in mitral valve reconstruction and carries his name remains the central tool of that procedure and has for 25 years. He is the most, has the most creative, inquisitive mind of anybody I think I know. He's a giant of a man. He's a wonderful teacher. He's a great speaker. He's a good friend, Carlos.
In most places around the world, the relationship between cardiologists and cardiac surgeon is short of not very good. Kind of competing for patients, each of them thinking that they have the truth and the final solution against what the other specialist is doing. And it has been an effort for many years on my part to think that the main issue really is the patient. It's not whether he's treated by a cardiologist, a surgeon, or a general practitioner. The important thing is the patient should get the best there is at that moment, which obviously is evolving. And what is the best today might not be the best in 5 years. But to achieve this close contact, and I'm a great believer in geography in terms of, you might think the same, you think the same as someone else, but the distance, the geographical distance, might change completely your perspective. And we all have a tunnel vision, and therefore the only solution to this problem is just bump into each other and organize meetings, organize this meeting that Stan just mentioned on Monday morning, where the patients are presented and each one present there gives his opinion. Says, in my opinion, this patient should have surgery. In my opinion, this patient should have this type of surgery. In my opinion, I don't think the patient should be operated and should have an intervention. Or in my opinion, I think you should leave him alone and give him aspirin. Because there are many alternatives and all of them are good. There isn't just the final solution, the final answer for everything. No, fortunately, there are many alternatives, and the issue is to find the best one. Anyway, in spite of all this presentation, as Stan said about himself, and certainly in my case, I never trained in cardiovascular surgery. I do not have boards of cardiovascular surgery. Why? Because it didn't exist. So you cannot train on something that doesn't exist. And when I was doing my internship and residency, that was in Paris, many years ago, 50, I just leave it at that in general. There were the occasional case of cardiac surgery, usually with a disastrous result. Mortality was incredibly high. It was around at least 50, 60%, at least. And so we just trained as we were having to solve the problems. Of course, it has been very exciting because in 50 years, we have moved a long, long way. And now if there is a mortality for a procedure around 5 to 10%, we start getting worried. And most procedures, standard procedures, they are around the 1% or below 1%. So it's a tremendous change. But it has been a bumpy road, I said, half century of bumpy road, because sometimes it has been very depressing when the patients die. Fortunately, it was diluted because we were doing all kind of other surgery. We were doing gastrectomies and pneumonectomies and lung disease, et cetera, and those they were doing well. But the cardiacs, they were not. Now, when having to talk about history of cardiac surgery, there is a kind of a watershed before and after cardiopulmonary bypass. Because now we try to get away from cardiopulmonary bypass, but in those days, that's what we wanted, to be able to get inside the heart. So most of the surgery that was done in fact, the first cardiac operation, real cardiac operation, was done in 1925 by an English surgeon called Sutar. He did one case of a mitral valve, and let me show. Yeah, more or less this. That's the heart, as Stan has been teaching us the anatomy, and the mitral valve is there, and the heart is pumping. You cannot stop the heart, otherwise the patient dies. So some surgeons had found out that they can stick a finger inside the heart, and the heart keep beating, maintaining the circulation. There's the finger of the surgeon, the index, going through what we call the atrial appendage. And if you have a purse string around and you tighten it, it doesn't bleed. So you can keep the finger there for a long time. The heart is beating quite happily and maintaining the circulation. Now the next problem is what you do with the index in there. And this gentleman, what he did was to split this valve, the mitral valve that was tightened and had a small orifice, with his finger, just by pushing through. And the patient survived. And he never did another one. And he was asked many times afterward, why didn't you continue? And he said, I hate to interfere with success. So I had a 100% success rate. because the next surgeons that started doing it were mostly in Boston, just after the Second World War, the 45. The first cases they did, they all died doing just that. And one of them, very famous, Charles Bailey, he was told by the hospital that if he did another of these operations, his licenses would be, his privileges would be withdrawn, because it was serious. I mean, they were just dying. And in the OR. So he organized 2 cases, one in the morning in one hospital and one in the afternoon in another hospital. And he did the 4th, he had killed 3, and there was a lot of fuss about it. There were editorials in the journals about it, in the professional journals. So he did the 4th case in the morning, and the patient died. And before any authority could do anything about it, he jumped in the car, moved to the hospital, and did the 5th case. And the 5th case survived. And that changed completely the whole thing. I mean, now it's just, another case. But then it was like the first transplant. It was a major thing. So that was what we used to call the closed cardiac surgery, because you didn't open the heart, you kept it beating. And then it evolved to using some instruments that we would stick through the tip of the ventricle and direct it with the finger. The finger would go through the valve, feel the instrument, get the instrument through the orifice, and you would open the dilator that would crack the valve open. And that was a fantastic operation. I have done certainly hundreds, if not thousands of those. And the patients were radically changed, and it's still being done in many places of the world because it's a simple and fast operation. And if you have a mitral stenosis, quite a good result. In fact, now it's done with a catheter, the same thing. A catheter is introduced through the orifice, and the balloon is expanded, and the valve is cracked open. Now, but the big thing was we have to be able to get inside and have a look, open heart. So there were a lot of hours of work, lots of animal work. I remember just days and nights working and trying to get the animal to come off bypass. That is, you put him on bypass, stop the heart, open it, close it. We didn't do anything else, and hoped that the heart would pick up and start. And it was difficult. The first one was done in 1953, again in Boston. Well, basically, for those that have heard about cardiopulmonary bypass, it looks complicated, but it's very simple. I apologize because I didn't have any slide, recent slide on cardiopulmonary bypass. This is a very old slide. That's the heart there. Now you have, as you know, you have the superior and the inferior vena cava that bring all the blood of the heart to the heart from the body. All the blood from the body goes through these 2 veins into the heart. So you put 2 cannulae, 2 tubes. One goes into the superior vena cava, and one into the inferior vena cava. When you put a tourniquet around, all the blood has to go through these tubes, obviously. So no blood in the heart. So you take the blood, that's the venous blood, and get it into the lung, the artificial lung, or oxygenator. And it sounds very complicated, but it isn't. This is an old model, but still, basically, it's easy to understand with this. All you do is bring this venous blood that has no oxygen and blow oxygen through the bottom. So you get a lot of bubbles of oxygen. Each bubble is like an alveoli in the lung. There's a tremendous surface area of these little bubbles, so that the blood gets oxygenated. But you get a lot of froth. So it was a lot of problems how to get rid of the froth, and eventually it was just practically by gravity, let it simmer little by little. Then the pump, this is a rotating pump, which is the actual heart. Artificial heart is just a pump, a rotating pump that gets the blood, the oxygenated blood, and pumps it back to the aorta, so that the body is perfused with very nice oxygenated blood, but the heart is not doing any work. Then, well, it can get more complicated. You don't lose any blood. There is any bleeding there is. You pick it up either from inside the heart or around the pericardial cavity, get into another pump, and then back into the circuit, gets oxygenated back in. So you keep the blood. Otherwise, you would run out of blood pretty quickly. So this was a revolution, and the first one was in 1953, as I said before, by a guy called Muller. And since then, it has evolved tremendously. Those machines were extremely complex, were huge. It took hours to clean them. And nowadays, they are just disposable and very easy to handle. Then the monitoring of the patient has changed radically. And there are specialists, there are perfusionists who know everything about this cardiopulmonary bypass, how to run it, how to handle problems. So it's a profession and extremely useful to cardiac surgery, essential to cardiac surgery. Now, that gave a tremendous opportunity. Now we can get inside the heart, and we started looking inside and finding fantastic things. And since there were a lot of valve problems at the time from rheumatic, the first efforts were to create artificial valves. So this is the first artificial valve called the Starr-Edwards. Starr was a surgeon, Edwards an engineer. It was a good combination that has been repeated all along. And the last kind of practical example of that has occurred here in Missoula, where a cardiologist, Stan Wilson, has an idea because he's seen the problems every day in the cath lab, and says, well, we are very good at putting stents into vessels, but when we have a vessel that is bifurcated, that is, that has two branches, we have to kind of select, where do I put my stent? If I put it to this one, okay, that part is going to be perfused, but this part is going to be maybe excluded from being perfused, which we call a bifurcated problem. And Stan thinks, well, there must be a way to solve this problem and be able to perfuse both, come from the root and then both rounds. And has an idea, and evolves that idea, then he needs the engineers. He cannot make it. Or he cannot even have an idea of the mechanical problems to produce the type of material, the design, etc. So it's a combination between the cardiologist, the surgeon who is seeing a problem, has an idea, and then the engineers. This combination happened in the case of Stan Wilson with Guidant company, which is very well known for these stents and catheters, to produce a completely new, because as far as I know, it's the only bifurcated stent available not in the States, but in the rest of the world, available for treating bifurcated lesions, which is unique. And that I don't know who gave it the name of Frontier. I think it's a great name, because we are a frontier state, Montana, as you know, and we have a tradition of the frontier, and this is also a frontier because it's at the edge, at the very edge of a new development. And well, so far it's been very successful. I think it's been used in 34 countries already, and every day 10 of the new frontiers have been implanted around the world. So today there will be 10 patients with Stan Wilson's Frontier. But that's a great example of this collaboration, which also we try to do here with the basic science. The way, again, the clinician sees the problem, but then the basic scientist comes along and we have a solution for this. So we try, and that's the basic philosophy of the Institute, of the International Heart Institute, to bring together cardiologists, surgeons, technicians, engineers, basic scientists, all with the direction of trying to solve problems that we have in cardiology. Now, that was the old one. See, just a ball? Simple, impossible. Still being used in some parts of the world. Fantastic, fantastic achievement. Of course, it has evolved a lot, and this is what we call the bi-leaflet. This is what you suture into the patient's heart, and this is the mechanical part with 2 leaflets. This is the open position. They have evolved fantastically, and they're being used by the million. An alternative to that is using tissue valves, and this is a PIC valve in what we call a pulse duplicator. It's a rig where you imitate the circulation and you can observe how valves work. And this is a PIC valve mounted on a stent. You can see it, how it opened. It's beautiful. And this is the closed position. Come on, open up. It doesn't want to open. Well, we move on. These valves, they can be mounted on stents. That's why we call it a stented valve. They're just plastic stents where you can mount inside this PIC valve that you just saw a minute ago. And I was privileged to be involved in the first cadaver valve to be used in a patient in July 1962. And then because we ran out of cadavers, is the problem now even today, we started working on the PIC valves, and that was in September 95. It was very exciting times when you know that you are participating, you are doing an operation for the first time, that you've been for years trying to work it out in the animal, and see that it works in the human. And that's the type of valve. See, there's the PIC valve there, mounted on a stent, on its way down. This is obviously the heart, on its way down to its correct position. And this is an alternative. In many cases, you don't have to replace the valve. You can use the valve of the patient and repair it, which nowadays has become, after over 25 years of insisting that it's better to keep your own valve, even if your tissue is not perfect, rather than the valve of a pig. And it's just using a ring, and you got the ring here with its holder, and then the ring in position. This, again, is inside the heart. See how dry it is? And this is the cannula bringing the blood back, and that's the ring in position there. Now, since then, we have evolved a lot, and this is the importance of science, of having laboratories here. I am very appreciative and thankful to the hospital, to the board of St. Pat, to understand the value of having research right next physically, back again to what I was saying at the beginning, right close together, bumping into the physicians, and the physicians bumping into the scientists. That demands a lot of effort on the part of the hospital, because space is very important in the hospital, and to dedicate some important areas of the hospital just for research, that's why I'm very, very thankful to their understanding and their vision, because I think that's essential to permeate to the whole hospital. As Stan was saying, it's not just the cardiologist or the surgeon, it's the whole hospital that participates in this search and fight for excellence. There is the same thing. If you want to have excellence, there has to be research. And why? Because the ideas can come from anybody. The idea, when people say, oh, if I were working at Harvard, I would do research there. But since I'm in Missoula, no research. This is ridiculous. The research is done not with laboratories, it's done with the brain. So if a nurse has a great idea, it might be a fantastic idea, and it can come from anywhere in the world. But you have to have a mind that is kind of open to watch your surroundings, what you are doing, and question it. Maybe I'm diverting, but they did a superb study here, the nurses in ICU. A group of nurses decided that they were going to look at the time that the patient was intubated. That is, from the moment he finishes the surgery to the moment that he's disconnected from the ventilator, from the respirator. And they said, well, there is a tremendous variation. Some patients seem to be able to take the tube out and they're breathing very well. And some patients will have to wait for 12 hours. Obviously, you might immediate answer, standard answer. There's the danger of standard answer. Well, some patients are worse than others. But they say, that doesn't work. It's true, but not completely true. Let's just collect data from the patients from today on, and then we look and see why. And they found that the main determinant for the length of time in the respirator was the name of the anesthesiologist. I said, well, isn't that interesting? And then they look, well, okay, I mean, research is not, blaming anybody, just see what happens. And it was obvious that the type of anesthesia was the main factor, because if the patient is asleep, you cannot extubate him. He has to be awake, so he cooperates and breathes in and out. So it was the anesthesia, the type of anesthesia, that determined the length. And now there are even now machines that tell you how awake you are. Little machines that you plug in a couple of electrodes on the head, and it tells you this patient is awake, man. And which is also interesting for during the anesthesia and surgery, because I've had patients that said, I heard you talking. I said, come on, you're dreaming. I said, no, I like the Mexican music that you had. Oh, damn. Caught. So what I'm trying to say is that it's the atmosphere of research in the center that matters. So that you question, and it doesn't matter whether you are the cleaner or the president of the institution. And that's what we try. And what I'm showing, or trying to show here, if I manage to get the wretched little, let's see, by putting little crystals inside the heart, that's the mitral valve, and this is the muscles of the mitral valve, and these are the tip of the heart. And these crystals, we get information of 200 images per second. So you have a 3D information of what's happening, I'm not going to enter into details, but you can see how you can go at the speed you want, you can turn it around, and you can measure. And the specificity of this measurement is fantastic. It's 0.02 of a millimeter. So if it says that the distance between this point and this point is 27.35, it is 27.35 millimeters. So it's fantastic precise. So you learn a lot how it works. And we are finding out that most of our ideas of how the valves work are wrong. As usual, that's the case. And that's the beauty of research. You usually find that you don't know anything about it, or that you were completely wrong. Now, coronary bypass, as Stan was saying, was the first, followed by balloon dilatation, what we used to call it PTCA, and then now the stents. And it's a huge numbers of patients that have benefited from this. It's grosso modo, it's 500,000 bypass done a year, and 500,000 balloon dilatations and stents, and increasingly the number of stents, of course, because it's less invasive and the results are very good. Now, these are the bypass that you're obviously very familiar with, where you take a conduit, whether it is from the patient or a vein, and you go from the aorta to the disease, beyond the disease in the coronary. For instance, when there is an obstruction there, well, the bypass will go here and then jump onto the next one. You can have another one here because there is an obstruction there. So you do 1, 2, 3, 4, 5 bypasses according to the needs of the patient, or 1, 2, 3 stents. This is how the stent, for those that haven't seen it, is a very simple drawing, but you get the artery here. This is the metal stent. See here, it's like kind of like a spiral, and this is the delivery catheter and the balloon. So you get to the place you desire under control of the X-rays, and you expand the stent against the wall so that there is a good blood passage. Another area that is increasing, and is probably the problem today, is heart failure. And the number of patients with heart failure is increasing. Figures from the 90s, we don't have the latest, from the 90s, it's 5 million patients with heart failure in this country and 500,000 new cases every year. And so the volume, some people call it an epidemic, the way that it's growing along the years, how the number is increasing and increasing continuously, and it's going to increase because, thank God, people survive when they used to die at 50 or 60 because of a heart attack. Now they tend not to, and they go on, but still they have the disease, so they come back, and therefore eventually they develop heart failure. Now, of course, the standard traditional, if you want to call any of these traditional, has been heart transplant. And I'm very fond of this one because that was my first heart transplant, which I did in 1980. And you can see, this is the donor heart. I have another one of the recipient heart, but I thought that I showed it to my wife yesterday and said, no, it's too much blood. So I skip it. But I have a picture of the patient who was a sailor, a professional sailor, and that's after, we used to keep him in a sterile atmosphere. He's a happy guy. And 2-3 days after the surgery, I went in and said, Jose, what would you like for lunch? Just ask for anything. You've been all these years about not eating with salt and, would you like caviar, anything? And he said, bacon and eggs. I said, well, that's an easy one. But that's him. Now, the problem with heart transplant, is that there are not enough donors. Look, these are the latest figures, from 2004. Total number of transplants done, 62,000 heart transplants. But the waiting list, this is the problem. 3,600 in the waiting list. 500 patients died while waiting for a donor. Unfortunately, the future doesn't seem to be very good for transplant because it's going down, the total number of transplants. In the US, it's going down from 4,500 in 2001 to 3,000. And it's going down. I'm sure in 2005 it's going to be even more difficult. And the mortality, the survival is fairly good. 10 years, 40%, half of the patients at 10 years are alive. The quality of life they have is fantastic. The main reason is not because they can do many more things, which they can, is because they appreciate what they have, which we don't. They really appreciate it every day. Every day is a present. Say, hey, this is a gift. I'm alive. So those years they have, they really appreciate those years. And I think that's very important. But unfortunately, as I just said, not a very good solution. The other alternative is the artificial heart. And there are lots. For years, I have not worked on that. People have been working on developing. This is one of them. And now the tendency, rather than saying, well, let's replace the heart with a mechanical heart, something simpler is what we call a left ventricular assistance, where you take the blood from the atrium and get it through a pump and return it into the aorta so that you help the failing left ventricle. And now they can be mobile. These patients don't have to carry, as in the old days, a whole machine every time they go for a walk. Now they can even go to the swimming pool and have not only a shower, but have a swim, and they have the batteries outside. And this is developing very, very fast, and now there are models continuously appearing, each one better than the previous one. Another development is what you might have heard, the minimally invasive surgery, which is trying to do the same surgery. All the efforts we had to stop the heart and look at it now is backpedaling and saying, well, let's try to not have to use the bypass, and whether we can not open the patient, and using different techniques without really, there are small incisions, try to work inside the heart from the outside. There's a lot of work going. The benefits, in my opinion, are mixed, particularly when maybe the best thing is they become very complex. Look at this one. You spend hours going around, and at the end, all you end up is seeing the assistant's mouth. They are very complex, extremely expensive. There are now robots that try to do this. I doubt if this is going to be the future. Now, another two developments that we're working here too at the Institute is tissue engineering. And you might have heard already in the papers, tissue engineering. What is it? Well, it's try to convince the cells of the patient, the recipient, to do what we want. And it is possible, because the cells have a tremendous capacity. In the last few years, there's been a revolution in cardiology that you get it even last week, a fantastic paper in Circulation, where we have cells in our heart that can produce new cardiac cells. We thought that, you probably know, in schools, we were taught in medical school, let alone in school too, that you were born with X number, 1 trillion or 2 trillions of cardiac cells, myocytes. And every time that you knock it, or you smoked, or you had an infarct, 1 million or 2 million cells died. Well, you were then 2 trillions or 3 trillions minus 1 million. And every time you killed, eventually you had not enough cells. That was the standard. Same for the neurons. We were born with so many, they are dying as you get old, and that's it. Eventually, there are no neurons left. Well, in some cases that's the case, I think, but that's from birth. Well, that's not true. It turns out that we have cells that can regenerate and develop into these specific types of cells. We call them phenotypes. And so the possibility is there. The only thing is we don't know the language. So it's having an army, but you speak in Chinese, or they speak in Chinese. Pretty useless, As a general, you can't tell them, go here unless you do this, It doesn't work. So with the cells, the same thing. What we are trying to learn, and that's molecular biology, is the language. Which language do they use? Do they speak in English or Chinese? And there is ways to convince them, to tell them, hey, do the job. Have you stopped to think, how come my baby that was this small, then he was this, then he was this, then he was this, then he stopped? Well, why doesn't he carry on? They're the same cells. Well, you grow, and you stop. Well, logically, you should keep growing. Provided you eat, you keep growing. Well, you don't. So there is someone is sending a message around and says, stop, go, die. Die. The messages that tell the cells, die, and the cell dies. You're getting lots of blood and no problem with eating. It doesn't die of starvation. It doesn't die because of a hammer hits it. No, it's healthy. It dies because it gets a message saying, you die. The cell dies. Which is essential, actually, to have, but we go into philosophy, it's essential to have this death. Otherwise, we wouldn't be here alive if we didn't have lots of cells dying continuously. So all this is tissue engineering. It's trying to produce what we want. And this is an example of work done here where we put a tube that has no cells at all, and you implant it, and if you have treated properly that tube, the cells of the host reconstruct the vessel, the wall, whatever you're making, in this case a vessel. So all these are living cells from the host that were not there. They came along, they creep in, and they repopulate that thing. And this is one of the products where you have a small tube from an ox, an artery of the gut, 4 millimeters in diameter, that you place it freeze-dried, it's completely dead, there are no cells there. You put it in, and within 30 to 50 days, it gets full of cells, as you just saw a second ago. Now, just close to finishing, what's happening now besides the tissue engineering? New things. Well, maybe this is the marriage between cardiology and surgery, which is the percutaneous placing of valves, so that you don't have to open the patient at all, you don't have to use any tubes and systems to see, because it's done in the cath room under X-ray control, and you take a valve, which we make here, you put it inside a stent, and you collapse it, and there's the valve with the stent, and you have a tube, a balloon, and a catheter. And when there you are, you expanded the valve and then you collapse the balloon and take it out. So the patient has the new valve inside, right? So that's the thing one of the things we are working on, and we are not the only ones, by the way. And although in France they have done already about 10 cases, not this model of valve, in humans. So there's a lot of interest because it's very interesting for the future for the patient to just have a valve replaced without having surgery, the death of surgery. Now, as Stan pointed out, what's the most important thing, or what's the message? Well, the message, as I said, is that the value of this putting people together, and so that ideas are generated, and this is one of these Monday morning meeting where we have the cardiologists and surgeons and nurses, anesthesiologists, even perfusionists, and we discuss the cases that are going to be studied operated that week. So I think it's a collaborative thing, and this is a very good example, what we're having today, of trying to make people aware how important this team approach to the treatment, the good treatment of the patient. Yes.
Why does a heart skip a beat? Why does the heart skip a beat?
The normal heart skip a beat.
You mean you mean all of us? We have occasionally, a heartbeat that just doesn't beat. But of course, when you have it very frequently, then it is a problem. The heart has a conduction system and kind of electric cables, and sometimes through a heart attack, sometimes just because of old age, those cables, like a normal cable, gets broken or interfere or fibrosed, or the surgeon cuts it accidentally, and then you don't miss just one beat, you beat many more.
Most extra beats most skipped beats are actually extra beats, and you're entitled to have extra beats. That's normal. And you're going along with the normal interval and you're not aware of it. You have an extra beat. The extra beat you don't feel because there isn't very much blood in the heart. It's early. The heart doesn't pump much. But the heart has a mechanism by which it doesn't go too fast. So it tells the next beat not to happen. Then there's a skip. And the beat that happens after that is very forceful because it's had a long time to fill the heart with blood. So the patient feels a pause, a skip, and a surge, thump. And that's all just one extra beat that does that, and extra beats are normal.
Well, number one is the heart transplant is really the most demanding procedure we have in cardiac surgery. By that I mean not the technical difficulty of doing a cardiac transplant is one of the easiest cardiac operations, the actual joining the new heart to what is left in the patient. So it's not difficult at all. What is difficult is demand a constant demand permanently on the whole hospital. It requires, and that's why in some ways it's very good, as Stan mentioned before, how having cardiology and cardiac surgery in a hospital, it brings a dynamics to the hospital. Well, the heart transplant is the same thing because, number one, they always perform at the wrong time. There's the Friday law, and there is an explanation for that, and it always starts at 1, 2 o'clock in the morning on a Friday night or a Sunday night, or Saturday night, which is very annoying. The lab has to be permanently in alert. The nurses, the transplant requires a tremendous amount of nursing hours and nursing care. So when you start a program, great excitement. If you just say, we are going to start a program on cardiac transplant tomorrow in St. Pat's, and we say, volunteers, it's going to be difficult to exclude people. Everybody wants to be a volunteer for the heart transplant. Not necessarily because they are going to come in the newspaper, which they are going to. Pictures of the transplant and all the nurses, the surgeons, blah, blah, blah. You feel all very important, did a heart transplant. Because I've been through starting 2 programs, so I know it. Now, within 6 months, half of the people want to get out of the heart transplant program because it's too demanding, and it's a bit boring too, because the patient is okay, but you still have to be on top of it. That's number one. Number 2 is the donors. That's the main one. The hospital that produces the donor and the nurses and the physicians are not very keen on it, because we have been trained to save lives. Now, in this case, the patient is dead, brain death. So and it's very, very important to look after that patient, that donor. Is not because he's dead. Normally, he's dead. Well, he's dead, Don't have to worry too much about him. No, in the case of the donor, you have to be extremely careful in how you handle it to avoid infection, to avoid fluid overload, a number of parameters. So it's a pain. So it's not that you are against the transplant. It's just that you are not stimulated to do the transplant. Now, I'm very aware of that because when I was the president of the Spanish Society of Cardiovascular Surgery, I had deals with the ministry because we had the same problem. I said, if you want to change and get donors, you have to change the system. And you have to encourage the donor hospital to produce hearts. And they changed the law. There's a national health system, a socialized system, and they get a lot of money now, the hospital, per transplant. The donor hospital, not the recipient hospital. And that money goes into not the pockets of the individuals, but into better equipment, holidays, things like that. Now, that has resulted into the number of donors in this country per million inhabitants is about 16, 17 donors per million. And in Spain is 25 donors, not quite double. And it's not because the people are different, it's just that they are encouraged to do it. And if there is no encouragement, why should you do it? So people is the tiredness, the demand, and the lack of compensation. Well, this is important because, as I was saying, Stan said before me, and I said it already, this is a team's work. It's impossible, and that's the beauty probably of cardiology and cardiac surgery, how much of a team is necessary if you want to have excellent results. It's capital. And these people here in the list I have, and not all, but most of them are here, they have, it's not what they're going to do, it's already what they've done for the past 30 years. And some of them, or most of them, have been here all the way through. But it looks impossible. You are too young for that. Eh? Anyway, let me read the list. Billy Billington, Sharon Bingham, Eileen Rounds, Bill Gemar, Randy Banky, Walter Lefevre, Jay Godreau, John German, Karen Turner, Jenny Hogan, Vicky Strait, Lida Stegers, Marge Gingras, Ann Anderson, Bill Anderson, Diane Ambrose. I'm quite good at pronouncing in spite of all the difficulties. Jan Hansen, Susan White, Mary Lawrence, Don Redeen, Gary Gilbert, Kay Johnson, Barb Westfall, Kay Lambert, Bonnie Farnham, Patrick Bewley, Hank McLean, and Jeannie Bow. Also, Jerry Dietert, Dr. Jerry Dieter. Where is he? Is he there? He's hiding. He's hiding.
There's a brighter pointer.
Dr. George Reed
Here too.
and Dr. Stan Wilson, obviously. Yeah. In the film. That's it. Thank you.
I wanted to introduce one other person, Jim Eggers. Why don't you stand up, Jim? Jim Eggers was the fourth patient to have surgery at St. Patrick's Hospital. And he had a heart cath, he had an operation. In the years that followed, he has been needed intervention on 5 occasions, most of those balloons in the PTCA era before stents, and the last time I think was stents, and that was 9 years ago, and Jim is still here and going strong, and this is what the gratifying part of all this is about, the patients. Thanks for coming, Jim.
I am Dr. Matt Maxwell. I am the head of cardiovascular surgery here at St. Patrick Hospital and am privileged to be so. I was sitting there, my job is to sort of be more integrative. I'm sort of like the 30-year people, only I'm only 7 years here. I'm more closer to the firing line. And I'm reminded of a metaphor. You know, to bend steel, it takes a certain amount of force applied repetitively, a certain amount of fire, and a certain amount of dedication to hitting that steel. And at the end of that process, everything's changed. From the coal, to the steel, to the hammer, to the blacksmith. And in many, many ways, people that you hear about here are each and every part of that process. Dr. Duran gave an elegant description of many of the things that have happened in the last 30 years, and countless thousands and hundreds of thousands of patients and patient families have been changed by that process. And we come today to celebrate some of that process, but can't lose sight of the fact that there are people who have given the better part of their productive lives refining that and honing that, from the people that stood here for that program to Dr. Duran. I came here first in 1993, having just finished my fellowship, to attend one of the symposia that Dr. Duran hosted. And I learned a little bit more about valve surgery that I wanted to, than I had known then. In 1997, I came here with a plan to stay for about a year or two to study with Dr. Duran, and then another surgeon was here, Jim Mowry, who had things that I wanted to learn. I thought I'd leave after 2 years, and they've come close to throwing me out on a couple of occasions, but I started to stay. Things change. People change. Roles change. But the one thing that hasn't changed is the dedication of the people around us and what it takes to make a productive program. I get to tell about a couple success stories today. I'm looking at one that I'm going to show you. And we get caught up in kind of how routine it is. I'll show you some of the routine parts. I'm also reminded that some of what we learned over the 30 years emboldens us to try and take perhaps bigger steps than we're able to take yet. And I'm reminded here recently of a patient who we operated on and did all the fancy stuff, biventricular assist devices and so forth, and there wasn't enough heart left to make it through, and she's died. And I don't mean to, we don't, by celebrating our successes and by praising those people who have gone through it, we don't We never lose sight of the fact of some patients who we have been unable to help, or patients that today may have something that we need the technology to develop, the research in the lab to be able to help them. And so sometimes bringing all that we have to bear is not enough. And for those patients, we're sorry and we miss them. And about 10 times a year, we come up short for whatever reason. It doesn't take anything away from the fact that we're at the 97.5 percentile for results in the United States of America for heart bypass surgery here in Missoula, Montana. And we're proud of that, and it takes dedication over the years for people like the nurses and technologists and physicians who stood up and did a lot of work before I got here, and will work a long time after I leave. So we thank you very much. We're mindful and humble of everybody's work that's gone through this. So with that, we get to talk about a couple of great patients. We have 3 patients, and they all represent a little bit different parts of the spectrum. The first I'm going to show you is maintenance, challenged by some genetic predisposition to early problems of the heart. We can do maintenance. The next patient is challenged by fate, and we can do incredible intervention. And another patient that you will hear about has done some life-altering changes, all of which facilitated by heart surgery or cardiology care, and all of which have been quite successful. So if we could show the video. The first patient is going to come up, it's going to stand after we get done, but the first patient had an aortic valve problem that was getting in the way of him working and living a routine life, and certainly going to get in the way of him living a life with a normal life expectancy. And this loop is a picture of his, this is a picture of his heart. Stop that for just a minute if you can. What we do when we identify the patient is to make some observations about their heart. And this is the aorta here. This is the heart catheter, that darker line. The heart muscle is down here, and we're injecting dye into his aorta, and that dye, the valve, as you've seen pictures of valves, these valves are one-way valves. They should open completely without resistance to flow and close completely so there's no regurgitant flow, so the heart doesn't have to work overtime. And if you watch this loop, dye that gets injected above this so-called one-way valve makes it back into the heart. And that's part of Scott's problem. Go ahead and roll it forward. You can see that valve. Stop for just a second. So this catheter is inside the heart. That's the heart muscle beating. This is a catheter above the valve, and you can see dye flows back here in the heart. This is the valve, his valve, Scott's valve, and this is white, is heavily calcified, and you can see that this valve doesn't open much. And at the end of this loop, I'll show you a normal appearing valve. But that's very thickened, non-mobile, and you can see in this picture, here's his aorta. This is the valve again, heavily calcified, not very mobile. This piece of valve should be disappearing up here, doesn't move at all. This is a picture inside the operating room from the echo. If you stop that for just a minute. What we do with the echo is we tag this blood basically with a color Doppler flow so we can watch the direction of flow of the blood, and we label it with colors that tell you about velocity, and this picture shows you that leak backwards in a different view. It just shows you the blood flow going backwards through a one-way valve. So this is not a one-way valve at all, Scott. It's a two-way valve, and it doesn't work very well. So go ahead and let it loop, and you can see this blue is blood coming backwards through that aortic valve and shouldn't be coming backwards. Okay, this is a normal appearing aortic valve. Look how thin that is, how mobile those leaflets are, how they disappear. And you remember in Scott's picture, that valve was heavily calcified, looked white like this. Here's a normal echo. Blood flow through one phase of the cardiac cycle only, doesn't go backwards. This is a short axis view of that valve. Here's a long axis view. Here's the valve again. Remember how heavily calcified those leaflets were and how thin they are here. This is the aorta again. This is again another picture of a normal. Notice it doesn't have that blue jet going backwards. So that's what it ought to look like. here you are, asleep. This is the incision. My hand was up there just to get you an idea. I'm not going to have him show you his scar. This is us. We've opened his breastbone now and separated it apart just enough so that we can get instruments in there to work. This is the pericardium, the heart sac, very thick and tough protection. Here's the heart, a little bit of scar from previous inflammation. Here's the aorta. We're freeing up the aorta from the pulmonary artery, which is over there, so we'll need to get access to a system. There's the right atrium, the right ventricle. Hugo Mendez, our assistant, is letting me put a ligature around the vein so I can get this blood diverted away from the heart. So we're going to open up this piece. The aortic valve sits right about there. I need to be able to get access to this aortic valve, and we'll do it by cutting through his aorta. Right now we're just putting a little purse string stitch through the aorta so we can put that cannula in there, hold it in place, and close that hole later when we're done with the cannula. All the while his heart beats normally. And actually you can watch this, watch the atrium beat first, followed by the ventricle. It's a pretty neat thing. That's normal rhythm. Lub-dub, 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 80 times a minute. Every minute you're alive, except for when we stop it to get to your valve, Scott. That's the aortic cannula so I can get blood to his brain. Here comes the venous cannula so we can get blood out of his body to get it to the machine. And you can see that blood's recirculated. It comes right up through the sucker, goes right back in the machine. So while the blood's free to the air, it gets salvaged and returned to him. And actually we did this operation with no blood, right? No blood transfusion, as I recall. That's right. So that's the venous return. It'll go to that pump that Dr. Duran showed you. We just secure it just so that it doesn't get pulled out. So we can make our attention to the valve when we get there. Getting the air out of the system is important. So we purge the air. We'll make connections to this circuit here. This bottom line here, this will go to the heart-lung machine. And the editor got fascinated by connecting this particular part. So now the heart's on bypass, but not stopped. And we're going to take this clamp here and put it below the arterial inflow. Now all the blood supply to the heart is going to be through what we do through this little cannula here. That'll give us oxygenated blood to the heart muscle. And you'll watch it, it'll stop. It slows down here, and we're giving it some medicine, potassium, to be able to stop the beating of the heart. Once it's stopped, we can give it nutrients through its regular circulation, and we'll cool it down so that it's in a state of almost hibernation, hypothermic arrest, so that it doesn't require a lot of oxygen. You'll see it slowing down here, and it'll stop. Here's the valve. We've opened the aorta. This is the aorta. We've opened up the aorta, and that's his valve, very thick, and it's a little bit difficult to appreciate, but heavily calcified. We took that out. This is a valve, a pig valve, that's mounted on this mounter and then sewn in place. And this is a different loop. This isn't from him, but this is what a normal aortic valve would look like. You'll see it a little bit better as we hold it up to the light. It's diaphanous, very thin, very mobile. Didn't look anything like that valve we cut out. And if you watch, there's a little bit better view of this in just a moment. You'll see those leaflets are quite delicate, and that's what they should look like. This is just from a different operation to show you what a normal appearing trileaflet valve should be. It doesn't show as well here perhaps, but actually it's better on a smaller screen. I'm sorry about that. Anyway, those leaflets, you see how thin they are and how pliable, and they don't have any leak shown with that picture. This is back to Scott, and in him I put in a little bit larger valve than he wanted to comfortably accommodate, so that little white thing there is a gusset patch on his aorta to enlarge his aorta to accommodate a little bit bigger valve, and that'll let his heart beat without resistance. That's his preoperative echo, just to remind you what it looked like. That's that heavily calcified, not very mobile valve leaflets. Again, the side view of it, this valve leaflet doesn't move at all. This one's heavily calcified, very thick, and the motion is quite restricted. His echo again, just to remind you. That's that regurgitant leak coming backwards through his heart valve. So not only was it stuck, it was stuck open. And now here's his heart with the new valve. You can see the new valve this is the stent, that white thing there and white thing there. That's that housing that holds the valve. Here's his heart beating again back in normal rhythm. Here's the echo, 0 leak backwards. And the velocity through that heart valve is quite a bit lower than what it was through his native valve. So here's the heart 45 or 50 minutes later, beating again quite normally. Here he is, still on bypass. You can see because the heart is empty. For those of you who've seen the full beating heart, that wrinkle there tells you that it's empty, so we're still on bypass. Here's the off bypass. See how full it is again. And again, that same lub-dub rhythm back to his normal rhythm. We had some cannulae in here which have been removed, and here we are sewing them back together. Scott, if you can stand up and tell us what's the date here. What was the date of your surgery? I didn't rehearse any of this with you.
3 weeks ago yesterday.
So 3 weeks ago yesterday. And the other thing to put the heat on him, not only does he get a new heart valve, and it's a little early to decide whether it, for the final effect to be there, and I don't know if you're feeling any different than you did before surgery yet, and I didn't ask him. It's pretty dangerous not to set the guy up and say, this is what I want you to say, I'll give you $1. Can you tell a difference?
Oh yeah, I can. Well, for one thing, my feet are warmer. I'm getting better circulation in my feet and my hands, and I'm still pretty sore through here, but you broke my sternum.
Yeah.
But yeah, I do feel better just all around.
The other thing that I wanted to tell him, and I did check this piece, is that he quit smoking around the time of surgery, as did his wife. And the other piece is that Scott's an employee of Montana Rail Link, which is its local piece and represents part of why we're here, to take care of our own people in western Montana. And so he is destined to get back to full activity, feel better in his life, and also we're mindful to address some lifestyle improprieties because his coronary arteries were pretty much okay. The first picture shows you he has a little bit of blockage, but we're also mindful that it's an opportunity to help people improve their health as well, so in a preventive fashion. Thank you for letting us tell your story.
Okay, excellent job.
Any questions about that operation or about Scott? So 3 weeks is a little bit early to be up and around and bragging, but we don't miss the opportunity to reinforce his improvements as well. Let me see what the next... I think there's a different patient story that we wanted to tell, and Dr. Sands, who is not here, was going to tell that. Well, I'll tell one out of order then. In keeping with this theme of Scott was maintenance, sort of came up and was challenged by this valve, probably set in genes, not related to his smoking, but set in his genes that his valve would wear out prematurely. This other patient, another now friend, is a little bit different story. Professor Flam, I'm most impressed by his contributions to horticulture. He was an orchardist before I met him, was pruning in his orchard, and living a pretty rewarding, semi-retired life. And as I recall the story, again, I didn't rehearse a bluff with him, but as I recall the story, he was down giving a guest lecture. Is that right, Barry? I was teaching a class. And was visiting with a student after having given a lecture when he was stricken by a series of events which would ultimately end up in his having emergency surgery. But what I'd like to do maybe is let Barry tell you his story, and then I'll tell you the heart surgery part, which is dramatic but less dramatic than his story. So Barry, can you come up and talk a bit?
I think the agenda shows my part as titled "Being in the Right Place at the Right Time," and that sort of sums it up. The first time I was in this facility, St. Pat's Hospital, was under rather different circumstances, and even though I thought I knew Missoula quite well, I had no idea where St. Pat's was, and I apologize, I never heard of the International Heart Institute. Heart problems were the last thing on my mind. I like the logo of the horse. I always like to think of myself as a strong and vigorous as that horse. So at any rate, January 30th, semester was just starting at University of Montana, and I talked them into allowing me to teach an environmental policy course, which has been really my life's work. I do a lot of international consulting, and at the time I was also a certified organic fruit grower, cherries, apples, and that. But my wife was enrolled in the business management program, so we were both headed down the first week of semester, excited and real anticipation of, I was excited about teaching. It would have been my second class, and spent the morning preparing, and my good luck, and I think the whole day is, some people might think of what happened to me as bad luck, but I think of it as good luck. And good luck started with a student who missed because of scheduling problems. My first class came in to get caught up. Her name is Joanne Woodward, and she's sitting across, we're talking, and I've never been shot in the chest, but I think it must feel something like that. And that's what I thought had happened. And she looked at me and said, "Are you all right?" And I said, "I'll be all right in a moment." And she took a look and decided no. And she went in and got Karen Hurd, the secretary for environmental studies, to call emergency services. And for the next few moments, I pretended to be working at my desk. And before I knew it, a nice ambulance crew arrived and asked me a bunch of questions like, what's your pain scale on a 1 to 10? I never heard of such a thing. So, well, ain't that bad. It's probably 2, maybe something like that. So, and they gave me, I think, morphine and some nitroglycerin, I'm not sure, and put me on a stretcher and hauled me down. It was snowing like crazy, and the ambulance pulled up the building right off the oval, and icy steps, and I'm worried about missing my second class. So I'm waving at the director, Tom Roy, saying, "Will you please send somebody to tell the class I don't think I'll make it back by 1 o'clock." And that's how kind of out of it I was. But once and then the ambulance driver, they were asking me a lot of questions. I thought, this is the worst soap opera I'd ever watched. And anyway, they asked me what hospital. I had no idea. I said, "How's St. Pat's?" Good enough for me. So I made an excellent choice, better than I ever dreamed. And I'm sure glad that Dr. Maxwell didn't get thrown out like he was talking about before, because I'm not pretty sure I wouldn't be here. At any rate, everything became kind of a blur to me, and I learned from Cheryl the other day when they were doing a video of some things I didn't know had happened. But anyway, everybody, it was so efficient, everybody was so kind, and I still remember I never got checked in, and I never checked out of the place. I must still be on the books, because there was no book work, nobody pestered me with anything. They just took good care of me, and they ran some tests, and they asked, "Well, can you do a stress test?" And I said, "Well, well, why not? Well, I think pretty soon they decided maybe a stress test wasn't the thing I needed. And I heard some serious conversations going on. And next thing, I think it was you, Matt, that leaned over and said, you got it, 2 choices, surgery, you die, or words like, something like that. And well, that's not too hard a choice. And I remember seeing my wife and daughter at last thing, and I kind of waved at them myself, everything's all right. And I'll have to say I was a little too much out of it to even be concerned about any of this. But anyway, one thing I was concerned about was getting my contact lens out, and I thought this would be a bummer to go through this and have my eyes damaged. And then I think that's just about the last thing I remember. And then the next thing I remember, a smiling face looking at me in the 9:30 the next morning saying, you did well. And that was Dr. Maxwell. Of course, I had this blissful sleep, and he had to go back in the middle early morning and do some more work on me. But not only is he everybody was terrific. Dr. Maxwell and his team did such a great job, but then he did more than that. That's why I get a little emotional.
Kind.
But he took so good care of my wife that night and looked after her.
Thank you. What Barry had, it's an interesting problem in that he was healthy, very engaged, and yet his story just touched on each piece of how we deliver important and successful health care and how a person gets reintegrated in their life. It starts with an informed public, a student who pays attention to her teacher and yet knows when not to accept what they've said. No, you're not okay. We'll call first responders. And then first responders show up and make the appropriate diagnosis. They care for him from his pain. He doesn't know the pain scale. He doesn't know the Heart Institute. He doesn't know a ruptured aorta from a Bing cherry.
True.
And yet they take care of him, care for his pain, deliver him to a place that looks at all possibilities. What could this be? It wasn't real obvious. The emergency room, emergency nurses and physicians, and ultimately the diagnosis of a catastrophe is made with no other alternatives but surgery. I would like to think I was a little bit more tender than saying operate or die, but maybe not. And then
you said that, or somebody looked like you said.
And then a prepared team in the operating room, a wonderful group of professional nurses and technicians to support all of the technology required to piece him back together. People to take care of his family when we can't be present, and there's this hours and hours of painful silence out of the operating room. Continued attention to detail. Something is not quite right yet, and back to the operating room we go. And then at the end of the story, a patient who, I have to tell you, gave me a little bit of a start, because I was thinking, there are some great stories out there. People who, like Scott, like Barry, like the patient we're going to hear from, who live here, have given large parts of their lives to our area and get paid back just a little bit for their investment in excellence. And I thought, well, how about Barry Flam? I was talking to Beth Schenk. I said, how about Barry? Gosh darn it, that's a great story. It's happenstance. It was luck. A lot of it's luck, and a lot of what we see is luck. He busts his aorta up in his cherry orchard. He may not be standing here. So some of this is happenstance. Some of it is just paying attention to the small details. It's to an informed public. And so I said, yeah, that'd be great, and I know he'll be a good speaker. And I call him on the phone, and the phone's disconnected, and my thought is, Jesus, he busted it again. Anyway, we're delighted that he's here, and we're happy for him personally, and also for what his story tells about the dedicated excellence and the importance of the general public as well. Each person here could have been in that same position to help save the life of Barry Flam. So thank you, Barry. Thanks for coming.
Thank you. I'd just like to say I've had a lot of fun these last 3 years, and I've hoped I've done some good things for the world. I've worked all around the world and been in some new slots like South Africa and parts of India I hadn't been in before, and had the best cherry crop the following year I ever had. So I think I tried to live up to all the hard work that all of the staff here, and it's just a wonderful place. I can't say enough about it. So, and I was real lucky.
Thank you.